Hi. So in this segment of the podcast, I'm going to go over what you kind of need to know in preparation and to perform induction of anesthesia. So the first thing that we're going to discuss is just your overall environment. And at this point in the day, you've started the IV, you've discussed your preoperative assessment of the patient, and you've brought the patient back to the operating room, and the patient is now on the operating room table. As we've reviewed before, you've made sure that your environmental controls are appropriate, that you've turned the heat up in the room so the patient is comfortable. And once the patient's in the room, you've covered him with a warm blanket. So now before we go any further, let's just do one last check to make sure that everything is in the right place. Now you want to go through your MS MAIDS algorithm again very quickly, but just make sure here that your monitors are functioning properly, that you have your vital signs, your EKG, your pulse oximetry, and your blood pressure. You want to make sure that your oxygen is turned on because you're going to be pre-oxygenating, that you have all of your drugs here ready for use, your endotracheal tube is styleted and ready for placement, and that your laryngoscope blade is working. Again, you want to make sure that your suction is available and right here at the head of the bed. And finally, just check the room one last time to look for any to make sure that you have all of your emergency equipment. So you want to always make sure that you know where your ambu bag is in case your anesthesia machine has a leak or you're somehow unable to ventilate the patient. You have an ambu bag that can assist you. And you also want to make sure that you have emergency airway equipment immediately available, such as a laryngeal mask airway. So once you have all of these elements in place, now we're ready to go ahead and begin preparing for induction of anesthesia. The first step is to make sure that you adequately pre-oxygenate the patient. I'm also going to, at this point, take my stethoscope and place it here around my neck. So for pre-oxygenation, you want to first explain to the patient what's going to happen. Now, induction of anesthesia can be a very anxiety-provoking experience for many patients, so it's important to be communicative and let them know what's going to be happening every step along the way. So I'm going to just talk to Mr. Johnson here for a second. Mr. Johnson, how are you doing?
Yeah, I'm doing okay. I'm a little nervous, but I guess that's normal.
That is normal. I just want to talk to you a little bit and let you know what's going on. You might feel your blood pressure cuff squeeze your arm kind of tight. Are you feeling that?
Yeah, it's a little tight.
Now, the first time it squeezes your arm, it's going to be kind of tight, but then once it gets to know you, it won't be as tight, okay?
Okay, it's squeezing now.
The other thing I want to mention is placement of the oxygen mask on the patient. Some patients are claustrophobic, and you might not know in advance, so I always like to warn the patient. So, Mr. Johnson, I'm going to put a little oxygen mask on your face. Is that okay?
Okay.
All right. It's going to smell a little bit like plastic, but that's normal.
Yeah, it sounds a little funny.
I want you to go ahead and take some nice, big, deep breaths for me.
Am I going to sleep now?
Not yet. I'm just having you breathe some oxygen. You are going to go to sleep in just a little bit, though, okay?
Okay.
Nice, big, deep breaths all the way in for me, and then blow all the way out. Now, the purpose of pre-oxygenation, obviously, is to fully denitrogenate the lungs, and so that we really restore that FRC to 100% oxygen. That's going to optimize your apneic time, which is the time from when you paralyze the patient to when you can definitively establish an airway. And by denitrogenating and fully pre-oxygenating that patient's FRC, you're going to be able to maximize the amount of time you have to secure the airway. While I'm pre-oxygenating, I'm going to go ahead and attach my syringes to the manifold. We typically will use an opioid, fentanyl. I'm also going to attach propofol here to the manifold. This is fake propofol. We ran out of real propofol in the simulator today, so this is fake propofol, but you get the idea. And then also we're going to attach our neuromuscular blocking agent, in this case vecuronium. So while I've done this, we've fully pre-oxygenated the patient, and at this point we're ready to start inducing anesthesia. I'm going to begin just by giving some fentanyl. 2 micrograms per kilo is usually sufficient to ablate the hemodynamic response to laryngoscopy. And I'm going to make sure that that medication gets flushed in. Now at this point it's also important to talk to the patient so that they understand when you administer the induction agent, which in this case is propofol, they may have some stinging in their arm, and that's normal. Mr. Johnson?
Yeah.
I'm going to go ahead and give you some medicine to get you off to sleep now, okay?
Okay.
Now, this medicine sometimes stings a little bit when it goes in your arm. That's normal. Don't worry about that, okay?
Okay.
I want you to pick out a nice dream. Everything's going to go great. We're going to see you when you wake up, okay?
Yeah, well, that sting.
I know, I'm sorry. That's just temporary.
Ow. Ow.
I want you to keep your eyes open for me, okay? Keep your eyes open. So I'm asking the patient to keep his eyes open so that I can monitor in real time the effect of the induction agent on the patient. And once I see those eyelids starting to close, and then when they're completely closed, I'll have an idea that the patient has been successfully induced for anesthesia. And I do see that. Now, to confirm that, you can also check for lid reflex by simply brushing your finger against the patient's eyelashes. And if you see no reflex to that, then that means that the patient is adequately induced for anesthesia. All right? So we're going to go ahead now and give a quick breath just to make sure that we can ventilate the patient, and we can. And we always like to check this before we administer the neuromuscular blocking agent. Obviously, if you had some difficulty with ventilation, then you would probably defer administrating a neuromuscular blocking agent until you could definitively establish that you could ventilate the patient. So I've administered the vecuronium. One more thing that I'm going to mention here is that we have another type of monitor that you can use, which is a neuromuscular stimulator. And this will allow you to check for twitches. And it's not something that anesthesia attendings or residents typically use at Stanford on a regular basis. But for a first-year resident during your first month, I think it's a useful device so that you can learn to understand the pharmacokinetic and pharmacodynamic differences among different patients in the response to neuromuscular blocking agents. And you can set this device to trigger a train of 4 nerve stimulation continuously during your induction until you see that the twitch fades. And at that point, you know that you've established adequate neuromuscular blockade for your patient. And during this period of time, you should also continue to mask ventilate the patient. There's another important thing I will mention, which is taping the eyes. It's very important to tape the eyes because you can inadvertently cause corneal abrasions if you don't adequately protect the eyes by taping them shut. And this is something that we discussed previously in our intubation lesson. So that, in a nutshell, is induction of anesthesia. I hope that I've been able to touch upon the major points here, which obviously are rechecking your MS MAIDS algorithm to make sure all your equipment is present in the room, to understand that you need to communicate with the patient during this very anxious period of time and let them know what you're doing each step of the way so that they know what to expect and they can be prepared for it. And finally, understand the type of drugs that you're going to be administering, the dosages that are required, and understand how to monitor the effects of your drugs to know when you've achieved optimal induction of anesthesia so that you can then secure the airway through endotracheal intubation, which is not something we'll talk today about, but we'll talk in our next lessons.